Welcome to this postgraduate lecture series as part of the MedEClasses initiative in which we try to cover the entirety of pediatric endocrinology over the 36 modules covering different aspects. And we have been covering electrolytes for the last few months. We already covered hypo and hypernatremia as well as hypokalemia. So today we're going to finish off the electrolyte module using the module on hyperkalemia. Now, hyperkalemia is a scenario which is usually an acute emergency and we don't encounter in terms of chronic causes, but that can have huge implications in terms of evaluation and management. So we had this 1-month-old child who presented with reduced feeding, and this child had not gained weight at all in that perspective, and investigation showed hyponatremia and hyperkalemia. So usually we talk about sodium and potassium being linked. And when we discuss electrolyte, we said that whenever your sodium goes down, generally the potassium goes up. When your sodium goes up, the potassium goes down. So this is again going a situation where the sodium is low, potassium is high, suggesting that there is a problem in the renin, angiotensin, aldosterone system. Now, further workup, of course, the first thing you will consider in a child would be to exclude congenital adrenal hyperplasia or adrenal hypoplasia congenita. 17-hydroxyprogesterone and cortisol levels were both normal. Now, if we go further our algorithm, we found that PRA and aldosterone levels were high. So we had a child who had a high aldosterone and despite that had hyponatremia and hyperkalemia, indicating that we are dealing with an aldosterone resistant state. So this led to the diagnosis of quote-unquote pseudo-hypoaldosteronism. But here comes a catch. So whenever you're making a diagnosis which is rare, you have to think of other possibilities. And we'll discuss subsequently that a pseudo-hypoaldosteronism-like state can be induced via infection and obstruction. So this actually happened to be a UTI in the setting of obstructive uropathy, which resulted in a transient aldosterone resistance, and that caused this scenario. So whenever you're diagnosing these scenarios, think about obstruction and infection, which becomes important in that regards. Now, this is the format which we'll follow. We'll start off a bit about pathophysiology of hyperkalemia. Then we'll move forward towards criteria and etiology with Dr. Vibha. We'll be discussing about, then I'll touch base about assessment and management. And finally, we'll have a quick, interesting scenarios and question answer sessions which Dr. Manoj will take forward. So all of you can participate in that using the chat option subsequently. We'll also be taking the questions at the end of it in that perspective. You all can go and have a look at our website, learning.growsociety.in, where there are a lot of resources with regards to pediatric endocrinology, besides a number of courses and our e-learning portal in the YouTube channel, and the various courses which are available, including fellowship programs, diploma programs, and we have an exclusive course for postgraduates which covers all these modules over a 3-year period, specifically for pediatric postgraduates in that perspective. You can also follow our grand rounds, which are more in a pediatric endocrine perspective, symposiums which happen regularly, in this PG lecture series, which we plan over the next 3 years to complete the entirety of pediatric endocrinology. You can also have a look at our multiple publications, which are there also in the form of physical as well as virtual platforms and our mobile applications. The key questions that a physician who is managing a person who has got hyperkalemia in terms of evaluation are 3. They are basically very, very clear. Is it really hyperkalemia? If it's hyperkalemia, what is the site of hyperkalemia? And finally, what's the cause? So in that perspective, of course, the most common features, as we discussed with hyperkalemia, they don't have any clinical feature. They are usually ECG changes. So if you've got classical ECG changes, if there is cardiac arrhythmia, particularly in the form of heart blocks, and if there is a sudden onset ascending paralysis, syncope, or weakness. But usually, the hyperkalemia is a very, very severe condition. So we need to preempt and get an ECG done before all these changes happen in that perspective. Now, the levels really have effect on manifestations. So the muscular changes typically start from around 6.5 when you will have paralysis. The cardiac changes start to have a peak tented T waves by around 5.5 to 6. As they progress from 6.5, we have the widening of QRS complex, you will have ectopic beats, and finally you will have loss of P wave and sine wave pattern will happen. That will happen very late in that perspective. So we are looking at peak T waves as an early manifestation of hyperkalemia, and that's what we want to evaluate. Now, importantly, the potassium levels are different and different ages. So we have to look for age-specific criteria, particularly preterm neonates and term neonates will have a higher potassium level. So we can tolerate levels up to 6.5 in preterms and 5.9 in term neonates. Infants, the level come down, and childhood typically level, which is above 5, we start worrying. Remember that blood gas analyzers will tend to give a lower value by 0.4. So this is something which we need to be correcting for when you're assessing in that regards. Since potassium is an intracellular ion, if there is a pressure, squeeze sample or a tourniquet, or if you have a very much increase in cell counts like thrombocytosis, you have got leukemia, or there is a polycythemia, those sort of scenarios will also cause a falsely high potassium in that perspective. Now, once we know that this is hyperkalemia, we want to then know whether it's largely renal or adrenal, and that becomes important. So look at urine output. Of course, if there is polyuria, you're looking at basically scenarios where they're losing sodium, but you're not losing potassium. That's like a Rast effect. Oliguria will favor renal failure. Tissue lysis, the history will be clear, like chemotherapy for ALL, hemolysis. And in DK, if you have a sudden onset pain in a particular area, there is a rhabdomyolysis which is happening. Look at the fluid status. In somebody who has got a Rast effect, you will have hypovolemia, while if there is an issue in terms of the fluid overload, effective hypovolemia, you may actually have more fluid. Ask always for the history of a potassium-sparing diuretic like amiloride, like aldactone, and also ACE inhibitors and ARB. Look for pigmentation to point towards primary adrenal insufficiency. Look for the genitalia to identify DSD, which could be XX and XY, which we'll discuss later on as well. Now, major workup, of course, is to exclude a renal failure. So look at urea and creatinine. And remember that if you have a Rast effect, there will be hypovolemia. You will have a high urea, and that may cause a bit of a confusion in that perspective. Urinary potassium is very important. Anybody who has hyperkalemia should have a high urinary potassium. But if your urinary potassium is low, this means it's a Rast effect, while if it's more than 100, it's typically a potassium load. There is another important investigation to look at is the urinary potassium to creatinine ratio, which basically corrects for the renal dysfunction. If it's less than 15 milliequivalents per gram, that is an indicator of inadequate potassium excretion. And in fact, this urinary potassium to creatinine ratio is emerging as a better indicator of the renal potassium handling as compared to the traditional TTKG or the transtubular potassium gradient, which I'll talk a bit later subsequently. Now, serum sodium is also important. As we discussed, sodium and potassium are usually opposing. So we expect that you will have hyponatremia in most cases. But remember, there is only one condition in which you have high sodium and high potassium. That's Gordon syndrome. That's a giveaway diagnosis in that perspective. Now, what's really is the transtubular potassium gradient? The simple thing to remember is that the major factor which is regulating the push of potassium into the lumen is the renin-angiotensin-aldosterone system. So we are trying to see what is the gradient of potassium in the blood as well as the tubule. So what it basically looks at is that you look at the potassium excretion in the form of urinary potassium and the plasma potassium, and you have to correct it for something. So you correct it for the osmolality. So as compared to other osmoles which are being excreted, are we excreting the same amount of potassium in the urine or not? So it's the ratio of urinary to plasma potassium divided by urinary osmolality upon plasma osmolality. So whether the potassium excretion is appropriate for other osmolar excretion, and this is potassium excretion, a major factor is the Rast effect, we can understand from there. However, there are a lot of lacunae in this test. You need to have a urinary osmolality which is reasonably high. So dilute urine will cause a confusion, and your urinary sodium should be reasonable. So only then you would be able to assess in that perspective. And if your TTKG is less with hyperkalemia, that is, you have got a high serum potassium, but less in terms of urinary potassium, this is a Rast effect in that perspective. Now, we have now known the site, renal or adrenal. We'll now go forward to the cause of hyperkalemia. So Rast effect, as typically already Vibha has discussed wonderfully, we have to look at a few things. Renin, of course, will be high in everybody, except if you have a primary renin problem, which does not usually happen in children. It usually happens in older individuals, people who have type 2 diabetes, in which the renal dysfunction is happening, and that's why the renin is going down, or you have a diabetic nephropathy, which is happening. If the aldosterone is low, we are talking with a hypoaldosteronism or maybe a CH variant. And finally, you will look at various parameters which will give you the clue. The most important, of course, is 17-hydroxyprogesterone and DHEAs, which will classify CH, particularly in infantile age group. And whenever you have a high aldosterone, high renin, get a imaging, get a urine routine microscopy to identify the transient form of pseudo-hypoaldosteronism. So the approach to hyperkalemia is that you look for any acute causes like renal failure, drugs, or tissue lysis. Then if all of them are not there, go for renin. If renin is low, this is hyporenism. Less likely in the pediatric, especially the neonatal population. Mostly you will have a high renin. And with that, if your aldosterone is low, it may either be an adrenocortical insufficiency or it may be an isolated adrenal aldosterone defect. So if your cortisol is low, it's a combined defect, a primary adrenal insufficiency. If cortisol is normal, you're thinking of an aldosterone synthesis problem. On the other hand, if you have a high aldosterone and a high renin, you're dealing with a pseudo-hypoaldosteronism. So here maybe you will look at whether it's a transient or a permanent cause. So the major investigation should be only done because often you will know the cause very clearly. You may have a renal failure, drugs are there, you know that there's tissue lysis, so 95% cases will go there. But if you have a chronic hyperkalemia, then you go ahead with these investigations and workup in that regards. Now, the most important age group in which hyperkalemia may present with a chronic one is actually the neonatal age group. And here, if you look at the genitalia and the size of adrenals, you will get the clue in that regards. So if you have an individual who has got a XX-DSD with enlarged adrenals, this is usually 21-hydroxylase deficiency. If you have XX or XY, this could be 3-beta and POR. And if you have a XY DSD with a large adrenals, you're dealing with a star defect. On the other hand, if you have a normal male who has got small adrenals, this is X-linked adrenal hypoplasia congenita. While if everything is normal, think of a pseudo-hypoaldosteronism and your aldosterone levels will be high. So always look at the neonate, look at the genitalia, get an ultrasound with adrenal size. 90% of cases, you will get the diagnosis where you are heading in that perspective. So for the neonate with salt wasting, hyponatremia, hyperkalemia, exclude infection and obstruction. Look at genitalia. If it's atypical and you have got no palpable gonad, this is XX-DSD, 95% will be CAH, 21-hydroxylase deficiency. Get a 17-OHP done. If it's high, this is 21-hydroxylase deficiency. If it's borderline, it could be 3-beta or 11-hydroxylase. If you have a palpable gonad, this is XY-DSD with salt wasting. Less common, look at DHEAS. If DHEAS is low, you're dealing with a proximal defect. If DHEAS is high, you're dealing with 3-beta HST. So again, look at genitalia and gonad, you will know how to classify. If the genitalia is normal and you have a male child, you can still have CAH 21. So get a 17-OHP. If 17-OHP is normal, you can still have adrenal hypoplasia congenita. Get an imaging done. If it's small, it is AHC. And if it is normal, then we'll go more in terms of pseudo-hypoaldosteronism. In a normal female, your 17-OHP may be low in star. If 17-OHP is normal, then you go ahead with evaluation for the rarer forms of hyperaldosteronism. And in that, you look at aldosterone. If it's low, it is synthesis defect. If this is high, it is pseudo-hypoaldosteronism. The crux is to look at genitalia. Then, depending upon the genitalia and the gender, you can then decide about workup for AHC and 21-hydroxylase in a normal male, and then only go ahead with the rarer forms of pseudo-hypoaldosteronism in that perspective. So we'll go through a few cases. 5-year-old child with syncope had hyperkalemia, was given antimalarial. So what we're looking at is an acute form of hyperkalemia here. And there was red urine, so there is clearly a hemolysis which is happening. So what are we looking at in a child who has received antimalarial who develops hemolysis? So the options you can mention on the chat. So this is clearly a scenario of tissue lysis because of G6PD deficiency in that scenario. 3-week-old child, failure to thrive with hyponatremia and hyperkalemia, not gaining weight in this time, dehydrated, which means it's more like adrenocortical rather than renal cause. Urinary sodium is high. There is atypical genitalia. So this is clearly, if we talk about that algorithm of neonate with salt wasting, atypical genitalia, no gonads, XX-DSD, 95-99%, 21-hydroxylase deficiency. So what you need to do is to do a 17-hydroxyprogesterone, very high. So this is 21-hydroxylase deficiency classically in that perspective. 3-month-old child with failure to thrive, again not gaining weight. There is hyponatremia and hyperkalemia. There is no pigmentation, genitalia normal. So adrenal causes become a bit less likely. We do a further evaluation. We find that PRA is high. Aldosterone is also on the higher side. This is pseudo-hypoaldosteronism, which is the more severe form, the recessive form. You will also have respiratory manifestations which may happen in that regards. 1-month-old child with reduced feeding, again not gaining weight. Sodium is low, potassium is high. 17-hydroxyprogesterone and cortisol are appropriate. So there is no adrenocortical insufficiency, and this is the first case we talked about. There is also a high renin and a high aldosterone. So this looks like a aldosterone resistance. But what will you do next in this scenario? You can write on the chat box. You have a neonate who has got salt wasting, who has got hyponatremia and hyperkalemia with a normal cortisol and 17-OHP and high renin and aldosterone. The diagnosis is pseudo-hypoaldosteronism. What should you do next? I think the most important point, which I've emphasized a lot, is don't rush to the diagnosis of PHA. Look at urine, look at ultrasound, and get the diagnosis. And that's very, very important from that perspective. So there was UTI, there was obstruction. Once you treat that, this child will be fine from that perspective and regards. 1-year-old child with failure to thrive, irritability, higher level of blood pressure, sodium is also high, potassium is also high. So this is an unusual scenario of hypernatremia with hyperkalemia. Only one differential which we have discussed, renin and aldosterone are on the lower side. This is classically a problem in the sodium chloride symporter. This is opposite of Gentleman syndrome. This is Gordon syndrome.